So, NEET PG. Everyone has a journey. Each student is special. And I would just like to share mine. Karnataka has always been my second home. ನಾನು SDM ಅಲ್ಲಿ MBBS ಮಾಡಿದೆ, ಧಾರವಾಡಲ್ಲಿ ಓದಿದೆ. And after that MS and MCH from BJMC Ahmedabad. And then again when I went on to do my fellowship in Bangalore, when my mentor asked, Prana Bharate, I said Bharate. Barlike Bharate, sir, Barlike Baralla, Matadlike Bharate. And that took me to nostalgia. Let's learn from our own Bangalore boy, Rahul Dravid. In a team where there were many stars, how he found his way. So what he has to say? He failed many times, but he never stopped trying. And I can surely relate my story to him, although I am not as successful as him though. But in my 12th standard, after scoring 77%, if somebody would have told me that I would become a neurosurgeon, then I would have laughed. Something similar to what he had to say when he was playing his under 19. All in all, I can say is entrance is just a part of life, not heart of life. Each day is a new day. Go back to sleep, get up fresh, and every day is a new beginning. I'll also like to quote one more quote from Sir Rahul Dravid, that no dream is ever chased alone. I was very fortunate to have a mentor, Dr. Vinayak, who was anesthesia PG when I was doing my internship in SDM. And I feel to excel in life, everybody needs one. I extend my hand to you all PG aspirants. If I can be a helping hand in your journey, I'll consider myself fortunate. You can always reach out to me on any of the platforms. I've already made an initiative. If you are somebody who does not like to see long videos, I've started something where we revise daily 2 MCQs in 2 minutes. That's my channel where I find time between my surgeries to make sure I release a video daily. And there are some 50 odd videos till now, 2 to 5 minutes each, not more than that. You can always have a look. So what is going to be today's class on? So it will be covering these 4 topics, starting from neurocutaneous syndromes, stroke, tumors, and recent advance. This will be today's class. The previous class we have covered on triage and trauma. I would also like to tell that if you have any queries, any topic which you want me to address or take, or any MCQs where you are stuck, please do mention in the comment section. And further classes, as Dr. Kishan said, that we'll plan further sessions on the way you want, because NEET PG is approaching and it's the right time to start revision. So let's get started. A tram and a track. It's a tram track calcification. And this is how the track actually looks. So a CT, chiral calcification with atrophy. And when I mean tram track, this is what I mean. The 2 tracks which are seen, that is the calcification on CT. On an MRI, we can see atrophy, can compare it to the opposite side, and this is the clinical presentation. What is this? Seizures. So our first question, all of the features of Sturge-Weber syndrome except, and these 4 are the options. So let's evaluate the options. So Sturge-Weber has the hallmarks of involvement of 5th nerve, that is V1, V2 trigeminal port vein stain, angioma, and glaucoma. There are various features of Sturge-Weber syndrome. If you want, you can remember, but for MCQ purpose, our keyword is hemangioma. So with our keyword, with the port vein stain, let's solve the MCQs. These are the picture-based questions which can come for Sturge-Weber. A child, adult with classical wine stain on the face in trigeminal nerve. And if at all, you just want to remember 1 or 2 points, tram-train calcifications and port wine stain. The gene mutation is also asked, gene X, and the chromosome is 9q21. So let's come to our MCQ. So all are features of Sturge-Weber. As I said, keyword is angioma. So hemangioma has angioma in it. Tram-track calcification we already seen with the pictures, and again an angioma. So this method is called ruling out the options and then coming to the answer. So the answer becomes easy. If you want to be successful in entrance, you have to live your life by MCQ. Suppose if you are gifted something like this, then an MCQ should come to your mind. What is it? Another image-based question. So a child presents with history of seizures, mental retardation, clinical examination reveals multiple macules. What is the likely diagnosis? And these are the 4 neurocutaneous syndromes which are given in the option. So let's see. Again, I'm giving a hint. If you see a Bonville, what do you think? It's a tuberous sclerosis, and the other name is known as Bonville's disease. So it's a genetic condition that causes growth in the various organs of the body. And there is an important triad associated with. You need not remember the name of the triad, but you definitely have to remember the 3 features of the triad: seizure, sebaceum, and mental retardation. So if you remember these 3, the MCQ becomes easy. So seizures is there in our option? Yes. Mental retardation is there in our option? Yes. And the third one, adenoma sebaceum. So what is the likely diagnosis? Tuberous sclerosis. And that's the answer. Ash leaf macule, Sjogren patch. These are the other 2 hi-fi terms associated with tuberous sclerosis. So MCQ point. If you come across any hi-fi terms, be sure the syndrome is tuberous sclerosis or Bonville's disease, except port wine stain, which is seen in Sturge-Weber. So that's how you remember when it comes to MCQs. And the 2 genes, genetics 9q and 16p, are the genes which are seen in tuberous sclerosis. 9q is what you have to remember, because Sturge-Weber is also associated with gene X gene, which is 9q chromosome, and this is also associated with 9q chromosome. So that's how you correlate and learn the MCQs. So next question. All of the following statements are true about neurofibromatosis, except. Now let's learn our third neurocutaneous syndrome, NF. So if you see a patient with so much, thousands and millions of swelling, we know it is NF1. And this image is going to give you answer to all the questions associated with NF, just this one image. So have a close look. You see from top to bottom, eyes, so optic glioma, skin, multiple neurofibromas, chest, pecs excavatum, axillary freckling, Cafe-Lou spots. If you come on this side, leash nodules again in the eye, scoliosis, freckles, and limb deformities. So let's come to our question. All of the following statements are true except cutaneous neurofibromas, obviously, cataract, yes, scoliosis, we did see, autosomal recessive. So, and rule of passing entrance examination, that is a rope point. All neurocutaneous syndromes are autosomal dominant inheritance. Take this rule, you will never make a mistake, you will never go wrong. All are autosomal dominant except Sturge-Weber, which is not inherited. It's a somatic mutation. So for all MCQ purpose, anywhere you see neurocutaneous syndrome, it has to be autosomal dominant inheritance. Now, which of the following is the most common tumor associated with type 1 neurofibromatosis? So again, if you remember the image, the first point was this, optic nerve glioma, and that's our question. So now if you learn like this, the questions becomes very easy. Remember students, all this have been questions of AIMS, recent NEET PG, and not my own made questions. So all these are repeats and are highly likely to come in the upcoming NEET PG. Plexiform neurofibromatosis affects which nerve? So this is some new entity and let's see what it is. So if you see a picture like this, where there is a swelling coming down the face, a boggy swelling or something like this, have a close look. One of these could be there in your image-based question in the upcoming exam. These are the plexiform neurofibroma. So 2 MCQ points. Plexiform are a feature of NF1. Second, they are commonly arising from trigeminal nerve. Also, one more correlation of what we have studied till now. Neurocutaneous syndromes, all are autosomal dominant, that we already know. Second point is they tend to affect trigeminal, that is fifth nerve. Remember, the Port-Weinstein was in V1, V2 segment of trigeminal nerve. So is this plexiform neurofibroma, which affects fifth nerve. Now, NF1 is covered. Let's jump on to NF2. So, NF2 is associated with which of the following? Do not get scared. Let's break the options. So, NF2 means you have to remember only one thing: bilateral acoustic neuromas or bilateral vestibular schwannomas. Apart from that, it is known to cause multiple lesions starting from brain, spinal cord, meningiomas, schwannomas, ependymomas, everything. But we have to see how does it relate to our MCQs. So before that, an additional information on anatomy of internal acoustic meatus, and although this is related to ENT and would have been covered, but let me revise. Anatomy of internal acoustic meatus, 3 points which you should remember. The vertical bar is known as Bill's bar, the horizontal is known as falciform crust, and the mnemonic 7 up, 8 down. That means 7th nerve is in the superior compartment and located anteriorly. And now, removing the controversy, acoustic neuroma, which is the most common nerve, a very often asked question and a very confusing options and answers given here and there. Take it from me, it is inferior vestibular nerve. Don't waste your time searching. I have already done enough research and it's an evidence-based answer. The common nerve of origin of acoustic neuroma is inferior vestibular nerve, not superior. Now, let's solve our question. So as I said, NF2, remember only one thing: bilateral acoustic schwannoma, and that itself is our first option. So this is another method of solving MCQ where you know the answer and you search for the same in the options. The second option is where you don't know anything, you rule out the options and then reach an answer. Trust me, there are only these two ways, and if you just keep it simple, you are likely to be amongst the top 500. So let's get started. Now, as we studied vestibular schwannoma, other name is acoustic neuroma. So don't get confused. There is one more image-based question or a NEET PG pattern question is ice cream cone sign. So as we can see, this is the cone, this is the ice cream, and this is the vestibular schwannoma. So this is how it looks in reality in a patient. And how does the ice cream cone form? So cone is formed by the intrameatal portion of the tumor, and the scoop is the tumor which is protruding into the cerebellum, going towards brainstem. What is my mnemonic? 2 cone. So after studying NF1 and NF2, just let's revise it briefly. So NF1, eyes, iris nodules, optic glioma, plexiform, 5th nerve, multiple lesions all over body, 6 spots and 2 neurofibromas. That's the criteria. And NF2 means 2 acoustic schwannomas or acoustic neuromas and multiple lesions. So now one more question. Where do their genes lie? That has been in the option as well as a direct question. So remember the mnemonic: NF1 is equal to 17, that is 11. NF2 is 2, that is 22, NF2 is 22, chromosome number is 22. So keep it simple, just remember one and the other one becomes very clear. So now coming to the next neurocutaneous syndrome regarding VHL, not true is. So VHL, you have to remember the mnemonic is 3 because it has 3 letters in it, and the full form is von Hippel-Lindau syndrome. So let's look at the options. Cerebellar involvement, short arm of chromosome 7, and these two are long looking options which we are not much studied about. So using our first method of ruling out options and then reaching to the answer. So let's get started. So VHL affects multiple organs just like tuberous sclerosis, but you have to remember VHL3. So 3 means kidney, adrenal glands, pancreas, although it involves more system, but just remember 3. Kidney, it causes RCC, adrenal gland, it causes pheochromocytoma and multiple pancreatic cyst. So why 3? 3 letters, mutation in the 3p gene, and AD is autosomal dominant. I said all neurocutaneous syndromes are autosomal dominant, and here is one more proof of that. This syndrome causes lesions in the tumor areas with large number of blood vessels. So organs which are richly innervated with blood vessels, those are the organs which are commonly affected. And remember this picture, it is going to come in one of the future questions. So there is a nodule and a cyst. Remember, it's a feature of VHL syndrome. So regarding VHL, not true is, now we don't know about third and fourth option. We know that we saw the radiological image MRI that there is a cerebellar involvement, but we only know one thing, rule of 3, VHL 3, and it is showing chromosome 7. Now that's what I call smart way of tackling the MCQ. If you don't know third and fourth option, that's okay, because the answer is already in front of you, and that's where smart work comes into play when solving MCQs. So next question on VHL. Multiple tumors are rarely seen. Which statement is true? Okay. One more mistake which students often make is missing out the except not word in the question. So there is no scope for this error of judgment. After reading for 1 year, there is no way you should lose a question by missing out this word. So reading the question fully, especially the last few words, is the most important. Take this tip, it will be very useful to you. So multiple tumor, so which statement is true? So multiple tumors are rare, craniospinal hemangioblastoma are common, supratentorial tumors are common, tumors of Schwann cells are common. Now we remember only one thing, that there was a cerebellar lesion and craniospinal hemangioblastoma. So remember, VHL is equal to hemangioblastoma is equal to pheochromocytoma is equal to RCC and 3p. So hemangioblastomas are the trademark lesions of VHL syndrome. And that's the answer. Now, all of the following are associated with VHL syndrome except retinal and cerebellar hemangioblastoma. Now we know, pheochromocytoma we know, RCC we know it. So now you all are expert, and by ruling out the options, we have come to the conclusion that gastric carcinoma was nowhere to be seen in whatever we studied. So that's again ruling out the options and coming to the answer. Now, all of the following hereditary conditions predispose to CNS tumors. Now, if you have been watching this part closely, you would have observed that we studied neurocutaneous syndrome. I always believe that the more simple you make the subject, the more easier it becomes. How? So, neurocutaneous means syndromes having CNS lesions as well as cutaneous lesions. And how are they related? They are related because both have embryological origin arising from ectoderm. So, if you have just paid attention, all these 3 lesions we have studied, and they are all predisposed to CNS tumors. Xeroderma pigmentosum was nowhere there, and That's the answer. Although it causes skin malignancy, that's an MCQ point, it does not cause any CNS tumors. So I hope whatever we have studied till now has been clear. All are autosomal dominant. Fifth now involvement is predominant. And all are neurocutaneous syndrome, that is skin lesions along with CNS lesions. So this completes the first half of our today's lecture, that is neurocutaneous syndrome. This is my favorite image because this is what I looked like when I appeared for my first attempt for my NEET PG when I was not qualified. I was standing like this, having read everything and was wondering which thing I have read where. And that's when I came up with this phrase, a picture is worth 1,000 words. So today, if you have to ask me whether I'll go for reading something like this and collecting facts or look at this beautiful image. So I tell, let learning be with pictures rather than learning pictures separately. And as a brain surgeon, this is my favorite quote. Eyes don't see what mind doesn't know. If you have not seen the image, let it be the simplest most one. You won't be able to get it right. So let it be picture-based learning, simple-based learning, rather than just mugging it up. So second topic of the day, stroke. That is a brain attack or a cerebrovascular accident. Let's again make it simple. Ischemia, hemorrhagic. Ischemia means less blood supply. Hemorrhage means more blood supply, so much more that the vessel ruptures and it causes hemorrhage. That's how you simplify and make it simple. So a patient who is known to have mitral stenosis and atrial fibrillation presents with acute onset of weakness in left upper limb, which recovered completely in 2 weeks. The likely diagnosis. Now we have to pick up the clues amongst a long question. So 2 weeks is an important clue. Acute onset is an important clue, and its comorbidities. 3 points, and you are right on your answer. So before that, let's simplify what is stroke. As I said, hemorrhagic, bleeding inside or in and around. Ischemia means low blood supply. With these just 2 tables, you will be able to solve, not only solve, but treat patients when they come to emergency. Because after all, we are all going to be doctors and treating the patient is always going to be our first priority. So hemorrhagic now occurs during sudden activity, that is activities of exertion, and it causes dense weakness, which is immediate. Also, it is associated with more mortality. Ischemic stroke, they are gradual onset with risk factors from hypertension, diabetes, smoking, unhealthy lifestyle, or embolic when patient like this in our question, where he has mitral stenosis, something like that. And if at all it resolves within 24 hours, then it is known as TIA. And that's when the question, the duration in our question is important. So now let's see the question. He has mitral stenosis and atrial fibrillation. So ischemic has 2 subparts, thrombus and embolic. Embolic means cardiac origin, where there is a predisposing cardiac condition which will throw a embolus into the brain vessels and it will cause its blockage. And thrombus will be thrombosis or occlusion per se directly into the intracranial vessels. So here it will be a embolic stroke and it has recovered, but within 2 weeks. So TIA is gone. Vasculitis will have other symptoms in form of constitution like fever, weight loss. So that is gone. Hemorrhagic stroke, as I said, it is more intense, more mortality, and it will not have these predisposing factors. So answer again by exclusion becomes ischemic stroke. Now, one question on ischemic, next question on, we know that it is a hypertensive hemorrhage, but which is the most common location? So that's a question. That is our second way of answering an MCQ, where you know the answer and you look for the option in your question. So ischemic, as we said, embolic or thrombotic, and the most common is MCA territory. That's again an MCQ point. Now our present question, which is hemorrhagic. So most common. Also, hypertensive bleed is also the most common in intraparenchymal compartment. And what is the most common site? Basal ganglia. But they ask this thing, putamen. So again, as I said, live your life MCQ style. So next time, when you go to a petrol bunk for refueling your tank, HP, hypertensive bleeds involve putamen. And that's how you revise an MCQ. So remember in my last slide, I told the most common territory involved is MCA territory, and this is what it is. So this is ischemic stroke. And if you see something bright like this, similar to the bone, so bright is blood, and that's what it is, hemorrhagic stroke. And this one is ischemic stroke. So how do you tell that this is the MCA territory? Just this, learn this briefly. No need to go into the depth because it's a super specialty level question. So a broad area is MCA territory, and aage, that is anterior ACA territory, will be in the front, and piche, that is PCA territory, will be behind. So that's how you remember ACA, PCA, and MCA territory. So let's come to our question. Hypertensive bleed is most common. Now we know HP. The answer is putamen. So next time you go for refueling, go to HP pump and revise this point. This is an image-based question which was asked previously. In this, the most common 2 points which you have to know is the vessel C and D. So this big vessel is ICA, that is internal cerebral artery, and it divides into two, middle cerebral artery and anterior cerebral artery. So this is the site for microaneurysms in a hypertensive patient which causes hypertensive bleed. And the C vessel is MCA. And these branches are known as lenticular striae branches. So MCA, and the artery which bleeds is known as Charcot's artery. Charcot's artery of hypertensive bleed. That's a point which you have to remember. Also, this kind of Charcot-laden crystals, although not related to CNS, but they are seen in amoebiasis. So that's how you prepare for an entrance, that when you come across a term, you have to try and correlate where you have learned something similar. So because in exam, you are not going to be given separate questions, that first 5 questions anatomy, then 5 questions physiology. No, you have to learn to mix and match and reorder. So let's get started. A 45-year-old presented in casualty with 2 hours history of sudden onset of severe headache with nausea and vomiting. On clinical examination, he had neck stiffness and right-sided ptosis. Rest of the neurological examination was normal. So what is the kind of bleed and diagnosis? So remember, the catch point in this MCQ are neck stiffness, right-sided ptosis, and a sudden onset of severe headache, which we also call worst headache of my life or thunderclap headache. And that's a classical of, let's go to the next slide and study. So these are the various type of brain hemorrhages which we have covered in detail in the previous video. If you have not seen, please do have a look. In this question, what we are concerned about is subarachnoid hemorrhage. Remember, worst headache of my life or thunderclap headache, it has to be a subarachnoid bleed. So if it's a bleed, we have to know the cause. Most common cause is trauma, and second most common cause of a subarachnoid bleed is aneurysm. And that's where the MCQ questions are coming up. So you have to go back to your childhood days and remember this wrestler, Triple H. He will help us solving at least 2 to 3 questions. So what is Triple H? First learn the double H, Hunt and Hess, and then the triple H, hypervolemia, hemodilution, and hypertension. How do you remember this? It's a simple way which I'll be teaching in the next few slides. So first, let's solve this question. So we know that he has sudden onset severe headache, neck stiffness, right side ptosis. Remember, SAH is known to cause neck stiffness. So that's the first MCQ point which you have to remember. Ptosis. PCOM aneurysm is known to cause ptosis because it points laterally and directly compresses the third nerve. That question is going to come, but first this question, now it is clear. The answer is aneurysmal subarachnoid hemorrhage. So circle of Willis. When it comes to aneurysm, you have to know circle of Willis. Don't go into the detail. I'll just tell you few brief points, which if you remember is more than sufficient. So circle of Willis was given by the same person. That's why his name, and it's a arterial vessels which are located at the brain base. And how do you remember them? So we saw the image-based question. Internal carotid artery divides into two, MCA and AC, and there is a vessel communicating them. So I'll draw and show you. So ICA, MCA, and ACA. And there is a communication vessel here, and there is a communication vessel which is here. So these two vessels you need to remember, the two communication vessels, one here and one here. And why these communication vessels are important? Because communication vessels are weak vessels and they give rise to something known as blebs or aneurysm or berries aneurysm. Why they call it berries? Because they look like the berries on a plant. And although classical, this circle of Willis without any abnormalities is seen only in 1/4 patients exactly like this, and there are various variations. So as I said, the most common site of berry aneurysm is, now remember, I told two vessels are important, junctional vessels, that is the communication between two ACAs and the communication between PCA and ICA. So junction of anterior communicating artery with ACA and junction of PCOM with the internal carotid artery, these two should be our answer. So let's see. This is a Berry's aneurysm where there is a communication between these two vessels and an outpouching has arisen and it ruptures like this, causing subarachnoid bleed, worst headache of the life, and thunderclap headache. So this is the entire chart where aneurysms can grow. All these are junctions. If you see, this is the junction, this is the junction, this is one more junction, this is one more junction. But what is important from our MCQ point of view? Communication vessels, that is anterior communicating and posterior communicating. How do you remember? A comes before P, so A is more common. That is anterior communicating aneurysms are more common than posterior. That's just a mnemonic to remember for you in the MCQ exam. So now we know A comes before P and that is the answer. Once there is an aneurysm bleed and there is a subarachnoid hemorrhage, there is a late neurological deterioration. And what is the most common cause? Hemorrhage, vasospasm, hyponatremia, and hydrocephalus. Hemorrhage is an early cause. Hyponatremia is also an early cause. So you have to rule out between vasospasm and hydrocephalus, which are late consequence. So you have to know which is more common. Vasospasm is more common, and 2 MCQ points. When does the vasospasm occur? So it occurs between 4th to 14th day, most common at 7th day. Hydrocephalus is also a cause, but not a common cause. Now, let's go back to our wrestler, Triple H. Triple H therapy includes all, but first you have to know what is Triple H actually used for. So Triple H is used to prevent the most common neurological sequelae, that is vasospasm. So if you want to prevent that, you have to use The hammer of triple H. And what is that? So I told you I'll make you revise and remember. First thing first, you have to give fluids, that is hypervolume. If you just remember this one, the next two becomes easy. So if you give more volume, there will be obviously hemodilution. That is our second option. If you give more volume, there will be volume expansion and there will be hypertension. So this comes our triple H. And we call it hammer of triple H. So now our question, triple H includes all except we know we are going to give volume. So what is going to happen? Hemodilution. So what will happen? Hypertension. And the answer is hypothermia. So that's how you remember the steps, so that you don't have to remember that hypothermia is not a part of triple H. You just have to remember hypervolemia. The rest three options become clear. Bonus point, hypothermia is used in treatment of raised ICP and not subarachnoid hemorrhage. So now triple H, I also told you remember the double H. So which of the following grading is used to prognosticate the outcome of subarachnoid hemorrhage? So where is the double H in our options? GCS no, Glasgow Blanchard no, intracranial hemorrhage score no. Where is the double H? It is here. Hunt and Hess. So let's revise. Hunt and Hess tells us the grading. Triple H prevents what? The most common sequelae of subarachnoid bleed, that is vasospasm. Now, last question in our vascular, and then we take a short break. So Denver's criteria is used for what? Now, there is no go. This is the NEET pattern, and you have to remember something like this. I have tried to make it interesting for you. I hope you have seen this perfumes ad where Shah Rukh Khan comes. And how I remember, if you spray this perfume, the smell is going to enter your nose and enter into your CNS. So Denver's criteria is for blunt cerebrovascular injury. It might come in your central exam where Denver's grade 3 is pseudoaneurysm. So if you want, you can remember, but this point you have to remember that Denver's is perfume. If you spray it, it enters through nose into your brain and it is blunt cerebrovascular trauma. Grade 3 will cause pseudoaneurysm. That's all is needed for you for NEET PG entrance. Confused between two options. Every entrance student, including me, have gone through this. That when 4 options are given, we often get confused between the two. You know why? Today I'll tell you. Let's look at this. These are how the multiple choice questions are set like. And the question is, which among the following is Aishwarya Rai? So if you see C and D, obviously they are ruled out. So the original Aishwarya Rai has to be between A and B. And that's what I want to tell you. The real MCQ starts when you rule out 2 options. And what most of the students make mistake is when 2 options are ruled out, something like this, the useless options are ruled out. That's when you try to rush in and mark a question. And that's where 90% of your 2 option confusion questions go wrong. Just do this thing. When you rule out 2 options, remember this image and tell yourself, now it's time to slow down, think, and use our 2 methods of solving MCQ rather than rush through. Because if you try to rush through between 2 options, take it from me, there is very high chance that you are going to make a mistake. So just remember, MCQs are placed in such a way or made in such a way that 2 options are always useless. So it is always between 2 options you have to choose. And when there are only 2 options, how can you get confused between the 2? So don't try to rush when 2 options are remaining. Just try to slow down, think, rule out, and then come to answer. That's the only advice, and that's the only way to come out this trap of 2 two options. Our character is not defined by the battles we win or lose, but by the battles we dare to fight. NEET PG journey is a fight, and everybody has got their own. And how do you fight this? Don't think about the result. You might be wanting to be in the top 1,000, but who knows? God has some other plans. He might want you to get in top 100. So don't think about the result. Just give it the best, and whatever you get, accept it. Because I'll repeat again, entrance is just a part of life, not heart of life. So let's come to the third and the most important segment of today's class, which is tumors, where there will be maximum image-based question. And that's why it's my favorite part, because I always believe in image-based learning. What you see is what you remember. What you remember is what you recall. And that's what becomes when you actually come across a question rather than mugging up. So let's get started to our third segment of the day, tumors. And this is the first question. So what is the most probable diagnosis based on the MRI image? So you have given this MRI image where you see a lesion. What is the diagnosis? So pilocytic astrocytoma, GBM, oligodendroglioma, meningioma. So seen the image clearly? Remember this beautiful butterfly. Why? Because that has been asked previously. What is that? Which of the gliomas is known as butterfly glioma? And the answer is glioblastoma multiforme. And why do they call it? If you know that, then you don't need to mug up. So you see the front part of the butterfly, and that's how the lesion looks. It's a poor prognostic lesion, and it is also known as corpus callosum glioma. Why do they call butterfly? Because it starts in one area and reaches to the opposite side, crossing the midline. So this has been asked previously. What can be the next question? If you see something like this, then you would say, Dr. Dhruv didn't teach us. So the posterior half of the butterfly, and it can arise from splenium of corpus callosum as well. So now you should not get it wrong. If you see anteriorly or posteriorly, but a lesion something like this crossing the midline, it has to be a GBM. So now the answer becomes very easy. It is glioblastoma multiforme. Next question. Which of the following is the most common type of glial tumor? So astrocytoma, medulloblastoma, neurofibroma, ependymoma. Just remember OAE. OAE are all the gliomas. So O is from oligodendrocytes, A is astrocytoma, that is from astrocytes, E is ependymomas from ependymal cells. So which is the most common amongst them? Astrocytoma. And amongst astrocytoma, what we saw? GBM is the most common primary brain tumor. If you see any question bank or any previous question papers, all these questions which we are doing are all been asked, all been repeated, and are high likelihood of coming in the next exam. So next question. A 35-year-old patient presents to hospital with headache, ataxia. On laboratory evaluation, there is a RBC count which was very high, and MRI was performed, and the image is given below. Remember, in VHL, I told you will see something like this. And what is the clue? Hemangioblastoma and RBC count high, because there is an abnormal erythropoietin production which causes the RBC to go high. So I have already given the answer to you, but let's reason out. Just a second. So if you see something like this, now remember, whatever lesions that are arising from cerebellum, that is posterior fossa, are known as infratentorial lesions, because this is tent, this is cerebrum, and this is cerebellum. So you see a lesion where there is a nodule, which is known as mural nodule, and there is a cyst. And you see similar lesions, a nodule and a cyst. There is one more entity which is confusing, but we'll be clearing the entire doubt in this slide. So, a nodule with a cyst, and there are two differentials for a lesion where there is a nodule and a cyst. And how do you differentiate? Age is the differentiating factor between these two lesions. So, if you see a child with a lesion, nodule and a cyst, it is pilocytic astrocytoma. And if you see an adult with a lesion, nodule and a cyst, it is hemangioblastoma. So don't get confused. You will be given in either of one of the options, not both. And even if it is given both, now you know that if it's a child, it will be pilocytic, and if it's an adult, it will be hemangioblastoma. So now let's come to our question. So it's a 35-year-old. So it's not a child. There is a nodule and a cyst, and the answer will be hemangioblastoma. Now, a very favorite question amongst the NEET PG aspirants. A 45-year-old female patient complaining of progressive lower limb weakness, spasticity, and urinary hesitancy. MRI shows an intradural enhancing mass lesion. What is the most likely diagnosis? So, the next slide is going to be very interesting. So, you see a lesion. It's a contrast scan and it's a well-enhancing lesion. This is a better image where you see a large lesion and two strings attached to it. So, what are those strings called? Those strings are called your favorite sign. And I'll give you a clue for that. It's a dural tail sign. And what is one more sign, which is actually a NEET super specialty level question? It's a mother-in-law sign. So why do they call mother-in-law? Because of the enhancement. Enhancement comes early and goes late, just like mother-in-law who comes early and goes late. So dural tail. So see this cat, and this is the tail. This is the lesion and this is the tail. So this is a dural enhancement. I hope it is clear because this is a very important point and I don't want any of you to miss out on that. So this is a lesion. Remember, the cat is the lesion and tail of the cat, and the tails at two ends. So that's what is known as dural tail sign. And whenever you see a dural tail sign, it has to be meningioma, but nothing else. Histology of meningioma has been asked previously once. And what is it? So it's a psammoma bodies. What is psammoma bodies? It's a calcification and there is wall-like appearance. So if you see something like a wall means it will be starting at a point and then going round and round. I'll draw for you. It'll be something like this. Yeah. So this is the walls. And not only brain, in spine also, if you see something like this with two ends of tail, which are tail of a cat, which we known as dural tail sign, it's again a meningioma. So now let's come to the question. 45-year-old, progressive and female gender. That is one more important point which I forgot. Female gender is more common, and there is one more question associated with which when it comes I will discuss. So female patient, lower limb weakness, and an MRI shows a lesion something like this, dural tail. We know it is nothing else but meningioma. Now, why lower limb weakness? This is an additional point if you want for detailed understanding. If you see the human motor cortex homunculus, which we call, that the face has the largest representation, so is the tongue and so is the thumb. As you move from lateral to medial, the representation of lower limb increases. And similarly, this lesion, it is flush to midline or close to medial surface. That is why this patient has lower limb weakness, and that's how you correlate in neurology. So next question. Now again, a 48-year-old female comes with bilateral progressive weakness. That patient had unilateral weakness. This patient is having bilateral weakness. So remember a rule in neurology: if the symptoms are, there are exceptions, but for your level, it is important you take this rule. For unilateral symptoms, the lesion is in brain. For bilateral symptoms, the lesion has to be in spinal cord. I repeat, unilateral weakness or unilateral deficit, the lesion is in the brain. Bilateral symptoms, the lesion has to be in spinal cord. So weakness and an image like this. We have already studied this. This is a lesion and there is a small tailing at both the ends. And now you all are expert. The answer is meningioma. Now, female gender. Why was I specifying? Because there has been a question previously like this. Which of the following tumor is not known to increase in pregnancy? Not known to increase. Don't miss out. Glioma, adenoma, meningioma, neurofibroma. Now, till now, we have only studied meningioma. We don't know about other two. So, remember this rule. Pituitary, which is a hormone-dependent tumor. Neurofibroma, not exactly hormone-dependent, but there is some role. So, hormone-dependent lesions are more common in females. And secondly, as we know that pregnancy is a hyperhormonic state. That is, hormones will be on higher levels. So, hyperhormonic state pregnancy will be causing increase in size of hormone-dependent tumors. That is pituitary adenoma, meningioma, and neurofibroma. So, the exception will be glioma. And again, we used our rule number 1 to solve this MCQ where we ruled out the options. Now, an interesting scenario. 35-year-old female who comes with a history of amenorrhea, galactorrhea, and bitemporal hemianopia. What is the most probable diagnosis? Now, just see this image and you will be able to solve this question. Galactorrhea, gynecomastia, sperms less in number, so infertility, and a lesion like this. So this is the way to study any clinical scenario for your good clinical practice, where you try and come to a diagnosis with pictures. So I call this pictures coming together to build or create a diagnosis. And the answer is prolactin. Prolactinoma, because all these are effects of hyperprolactinemia. A beautiful snowman in winter and a lesion like this. So next time you see a song where there is ice rain and a snowman, you should think about this MRI. So does it look like a snow? Snowman, yes. And that's where the 2 MCQ points come. Snowman appearance or figure of 8 appearance is a feature of pituitary adenoma. So I hope you are learning, you are enjoying, and you are learning image-based way where you are not mugging up. You are seeing actually how they call it. See, if you just try to remember snowman appearance in pituitary adenoma, snowman appearance in pituitary, that doesn't work unless and until you actually see a lesion and then see a snowman, keep it next to, and then you see. Yes, they have named it for a reason. Also, it is known as figure of 8, which is very clear. So figure of 8 and snowman appearance is seen in pituitary adenoma. So now we know 35-year-old, amenorrhea, galactorrhea, and bitemporal hemianopia. Why bitemporal hemianopia? Because optic chiasma will be here. The structure optic chiasma will get compressed, and optic chiasma compression causes bitemporal hemianopia. That's again a separate topic, but just remember this is a feature of prolactin secreting pituitary adenoma, that is prolactinoma. Remember this cartoon character? Now you remember who who he is? The great Hulk. And what do we call him? Acromegaly. And the other features of acromegaly: spade-like hands, long fingers, prognathism, broad jaw, gum hyperplasia. So if you see something like this, again, we are creating or building the diagnosis. And along with that, if you are given an MRI plate, even if you don't see the lesion, if you correlate all this, it is GH adenoma. So this is a case of acromegaly where there is a pituitary tumor which is causing growth hormone hypersecretion and causing this sort of clinical presentation. Now, one more scenario which we have been reading since long time: moon-like face, purple stripe, buffalo's hump. But how do all this occur? A small pituitary lesion known as pituitary microadenoma or ACTH secreting adenoma. All this can be, if not in the MCQ, is definitely going to help you in your clinical scenario. So we have seen 3 clinical scenarios. Let's revise for you guys. So first, galactorrhea, gynecomastia, infertility, and a lesion, which is prolactinoma, snowman appearance, figure of 8, pituitary adenoma. Our great Hulk, features of acromegaly, it's a GH secreting pituitary adenoma. And last but not the least, Cushing syndrome, features of Cushing syndrome because of a pituitary lesion. And next. So now, till now, whatever we have learned, let's put into practice and solve the further MCQs. So which of the following is not true about pituitary adenoma? So accounts for 10% of brain tumors, erodes the cell extending to surrounding area. Prolactinoma is the least common, differentiated by reticulin stain. Now, if I am the appearing aspirant, I don't know anything about the first, second, and fourth option. But only thing I know is prolactinoma I was taught nicely, and that means it was common. So again, just by exclusion, I will write prolactinoma is the least, because prolactinoma is actually supposed to be the most common functioning pituitary adenoma. And not just like that. You have to also, that is another way from learning from MCQs, that you have to see the options of MCQ and build up your theory rather than just reading theory and then coming to MCQs. So pituitary adenoma accounts for 10% of brain tumors. That's one point I have learned. It is erodes the cell line, extend into the surrounding area. Yes, that's what I have learned. It is differentiated by reticulin stain. Bonus point, reticulin stain is a feature of normal pituitary gland. If the normal pituitary gland pattern, that is reticulin stain, is destroyed, that means it is pituitary adenoma. So that's a bonus point. Now, if you have diagnosed in your MRI, you have seen the lesion, it has to be treated as well, right? So the most preferred approach for pituitary surgery at present time is just this one image and don't try to mug up. So you go through the nose. What is this? Sphenoid sinus. Anatomy, floor of the cellular fossa is the roof of sphenoid sinus. So what is the significance of cellular fossa? Pituitary gland, pituitary adenoma are seated here. So if you want to treat, you have to go through sphenoid sinus. If you just know this anatomy, your answer becomes very easy. So just one image and you need not mug up. Now, a completely different entity. Till now, what we studied was middle-aged females presenting with so-and-so symptoms or male patient presenting with so-and-so symptoms. Now, there is a 15-year-old young boy who has come with headache, vomiting, visual complaints. On examination, there was signs of growth retardation. MRI is given. What is the most probable diagnosis? Now, if I was a PG aspirant, I would think, oh, again, it's a pituitary lesion. But oh my God, pituitary is not at all there in the option. So What is this lesion which is there in cellular floor? This is a sphenoid sinus. It is going into the supracellular component. What is this? So this is another huge lesion in that region. A nodule with a cyst. Again, same. And remember the optic chiasm? That's why he's having visual disturbance. Take this rule. A solid, this is a solid nodule. A cystic lesion plus a child is equal to nothing else but craniopharyngioma. So 15 years old, visual complaints, growth retardation, nothing else but craniopharyngioma. Now, questions related to craniopharyngioma. So all are true of craniopharyngioma except, now we don't know how it is derived, contains what, but I studied that it was there in the cellular fossa and it was going above. That's what I know. So this is how you learn from one question and solve the other. So just you saw that image had cellular and supracellular extension. And what is this showing? Present in cellular and infracellular. No. Infracellular was not there. So that's my answer. And again, our first rule of solving MCQ, rule out the options and come to the answer. Dumbbell tumor is seen in. So I hope you all have seen a dumbbell or maybe worked out on that as well. So dumbbell tumor is seen in what? Now we know that is a lesion, but we don't know what is it. Is it a meningioma, neurofibroma? What is it? We don't know. So just remember, this is a cord and these are the nerve roots which are coming out through the foramen. So if nerve root is coming out, there has to be a pathology associated with nerve. Where is the nerve? Nerve is here. So the answer is neurofibroma. So if you just know anatomy, you have not studied what is dumbbell tumor, but still if you know that nerve root is coming out through here, you can still come to the conclusion and get this question right. Now, another very related MCQ to this, widened neural foramina is frequently seen in what? Neurofibromatosis and all this which we have already studied, but we never came across this entity. So what is it? So that's a dumbbell. Dumbbell has two thick ends and a narrow waist. So this is a thick end, this is a thick end, and there is a narrow waist. What is the narrow? Actually, it is supposed to be this much only, but this has become widened. You can see it has become wide. This is narrow. Let me use a pointer. So this is the first end of the dumbbell. This is the second end of the dumbbell, and this is where it was supposed to be like this, slim trim, but it has become widened. And what is this lesion? We know there is only one structure which comes out from here, that is nerve. So it is a neurofibroma. Where do you see neurofibroma? Neurofibromatosis. So that's how easy it is when you learn with images. Nerve-sheath tumor, dumbbell-shaped neurofibroma. All these hi-fi entities are now peanuts for you. Now, this is something which you have to mug up. No go. Pathological joking. It's seen in what? I'll just tell you one thing. Loss of inhibition or anything related to behavior is associated with frontal lobe. So pathological joking means excessive joking, making fun in each and every small thing. So that is associated with frontal lobe tumors. Now, which of the following is not true about medulloblastoma? So 5 options means that has been a PGI question, and this question is going to teach us a lot. So how? I'm sorry. So what you see? So small round blue cells, and a famous entity, small round blue cell tumor. And the same thing you are seeing in histopathological. There are small round millions of cells. And there is a central fibrillary, which is a famous rosette, Homer right rosette. So this is how the lesion looks. It's a infratemporal. Why? Because it is arising from cerebellum. So this is a cranium lesion, and this is the small lesions of a similar patient which has come down to the spinal cord as well. So what is it? Medulloblastoma. And important entity, loss of 17p. So now let's see how we can use this to solve our question. So which of the following is not true about medulloblastoma? Now, radiosensitive tumor, we don't know. Spreads through CSF? Yes, because remember, along with brain, I showed you an image of spinal cord where there are small lesions. So that is through CSF, it has come down, which is known as CSF seedling. Surgical treatment is definitely indicated, occurs in young age group. It is a supratentorial tumor. Now, only point which I don't know or which I am sure is, it was there in the cerebellum, and cerebellum means it's a infratentorial tumor. So how can this option be correct? So the answer by our first rule of solving MCQ is it's a supratentorial tumor. Chang staging, no way out. You have to remember Chang is used for medulloblastoma. You can remember the code CM, Chief Minister. Chang is for medulloblastoma. Prophylactic craniospinal radiation is recommended in which amongst the following? Now, prophylactic radiation is commonly given for tumors which are known for CSF seedling. So out of these, there are two tumors which are known for CSF seedling, that is spread through CSF into the spinal cord, medulloblastoma and ependymoma, because both are infratemporal lesions and can spread easily. But out of these two, prophylactical indication is for only one lesion, that is medulloblastoma. Now, a repeat MCQ which was asked previously in some exam, just 3 points and that's it. So IDIM, IDM, ED. What are these? These are the spinal cord tumors. And what does this stand for? ED is extradural, IDEM is intradural, extramedullary, and IDIM is medullary. So you need not mug up. This is the cord. Tumor is within intradural, intramedullary. This blue line is dura, and this is cord. So intradural, extramedullary. So it's outside the medulla, but within the dura. And extradural is completely outside our dura. So extradural. Now, MCQ point is least common is intramedullary. Two options you need to remember, astrocytoma and ependymoma. Second most common is IDM, that is neurofibroma or meningioma. But what you have to remember is most common is extradural, and the most common pathology is metastasis. So CNS tumor presentation with calcification. A very interesting slide coming up. You see a chicken and you see wires, and you see an egg into an omelette. That is fried egg appearance. This is the egg and this is the halo around it. There is a story behind this. A British man was asked to build a fence for safeguarding the chicken, and instead of cloth, he used a wire. So that's what it is known as, to safeguard the chicken. It is chicken wire, and these are the branching pattern of chicken wire. So multiple MCQ points, fried egg and chicken wire appearance as feature of this lesion. And what is it famous for? Calcification. How do you know? This is a bone which is calcified, and you see a bright rim here. That is a calcification. It is nothing but ODG, oligodendroglioma. So the CNS tumor with calcification, first answer has to be oligodendroglioma. There is one more lesion which we discussed, sella suprasellar cystic solid lesion in a young male patient, that is craniopharyngioma. There is a rule of 90 for craniopharyngioma. First, let's solve this MCQ. So answer is oligodendroglioma. Rule of 90, which you missed out in craniopharyngioma, is 90% is seen in children, 90% is cystic, and 90% is calcified. So calcification, remember, calcification oligodendroglioma, calcification C for C, craniopharyngioma. And the last question of our brain tumor section, all of the following are features of brain tumor except. Now, if you know the anatomy, this question is easy. Seizures, headache, and focal neurological deficit are all features of supratentorial compartment, that is the cerebrum. Pinpoint pupil is classically seen in pontine hemorrhage. PPP, pinpoint in pontine hemorrhage. And that concludes us to our tumor section. Another 10 minutes to go. So please stay tuned. Don't go anywhere. Just before resuming the next section, that is the recent advance, the last part, let me take a short break and let me give time for you to think. This is the image of Virat Kohli in 2010 when RCB, when he was playing for RCB and RCB could not make it to the qualifiers. And this is his image when he single-handedly won us the T20 match against Pakistan on the day of Diwali. And what he said, if you are not God gifted, compensate it by your hard work. And how hard can you work? This guy went without a single cheat day for 2 consecutive years. No festival, no birthday. And that's how it is. So I say, sports teaches you life lessons. Kobe Bryant, famous basketball player, said, I don't want to say, I wish I could have. Just one thing which I want to tell you, there are many people who are more talented you, but there is no excuse for anyone to work harder than you. Your work ethic should be simply standing out from rest of you. And that's what will make you stand amongst others. One last thing, your exam results do not define who you are as a person and predict your future. Again, entrance is just a part of life. So try again, fail again, but fail better. So I hope this was a useful break and let's move on. Let's wrap up this session in another 5 to 7 minutes. Few MCQs, recent advance, let's get going. So most common site of abscess in patients of cyanotic heart disease is one of these. Now, brain abscess. Few bullet points, just note it down. Abscess is seen comparatively in younger patients, and depending on the infective focus, always abscess in brain is secondary from the nearby. So you have to think what is the most nearby structure from where the infection is spread to brain. So simple, CSOM, that is ear. So what is a lobe which is very much near to it? Temporal lobe. So the temporal lobe abscess. Sinusitis or dental infection, which is the lobe which is nearest? Frontal lobe. So frontal. And cyanotic heart disease, it's a blood-borne spread which is causing parietal lobe abscess. Remember, abscesses have shorter duration of presentation. They present with seizures, focal deficit, and the investigation of choice is MRI, with surgery is mandatory, and 6 weeks of antibiotics. But how do you diagnose? A lesion which looks bright on diffusion, that is a bright spot. And how do you differentiate it from GBM? Our butterfly glioma, quite different. And the most important, there is no bright spot in GBM. So bright spot is nothing but restriction on diffusion. How does it happen? It's not required. So simply don't go into the depth. So now we know cyanotic heart disease, it is parietal lobe, and temporal will be from CSOM. So application of our previous learning in this MCQ. A young man presents with long history of sinusitis with fever. Now he has developed personality changes. So revision of our 2 previous MCQs. Sinusitis, which is the lobe which is nearest? Frontal lobe. Personality changes, pathological joking. Remember? So where is the lesion? Frontal bone osteomyelitis, frontal bone abscess. These 2 have been ruled out. So again, confused between 2? No. The options are actually 2. These 2 are rubbish options. Now, why is osteomyelitis not an answer, or why frontal lobe abscess is an answer? Personality changes and fundus shows papilledema. Papilledema is a sign of raised intracranial pressure. That means there is a space occupying lesion within the brain. Osteomyelitis is within the bone, not within the brain. So the answer by logic and our rule number 1 ruling out the option, it becomes frontal lobe abscess. Now, which is the most common location for intracranial neurocysticercosis? So just enjoy this small GIF. It's a tinea solium, that is hookworm. So just bullet points: young male patient, first time seizure, multiple calcified lesions like this. This is a CT. Now we know how we recognize CT. So small multiple calcified lesions. On contrast, they will be ring enhancing, and on T2, there will be center hypodensity, which is nothing but the scolex head. Is nothing but neurocysticercosis. But which is the most common location? That was not answered. So it's a blood-borne spread, and brain parenchyma has the maximum area amongst all this to spread for the infection. So the answer by knowing this is our rule number 2, which we are using to solve the MCQ, where we cannot rule out. So we have to know it, that brain parenchyma has a large surface area first, and it has a rich blood supply, and we know that it's a blood-borne infection, so it will be brain parenchyma. Last 3 questions coming up, so please stay tuned. Stimulation of which cranial nerve is considered as treatment of epilepsy? Enjoy this gift. I hope you remember the movie, it's Hangover, and what is written? Vagus, and this guy is having involuntary movements. He's having seizure. So we want to treat seizure. So where do we need to go? Vagus. And which cranial nerve is going to take us to vagus? It's a 10th cranial nerve. And this can be an image-based question where you see something like this, and they will be asking which cranial nerve stimulation is done via this device. And the answer is vagus, that is 10th. Now, these are the image-based questions which have been asked previously. What is this? So it's a ECOG, that is electrocorticography. These are the grid electrodes, and the question which was asked was which surgery they are doing, or which surgery they are trying to do. So they are trying to do epilepsy surgery, and via this grid they are trying to know which area of the brain the epileptic focus is arising, so that we can remove that surgically. So last topic of the day, SRS. SRS is used in which amongst the following most commonly? GBM, medulloblastoma, ependymoma, or AVM? Now, SRS, first we should know the full form. So it's a radiosurgery, which is stereotactic. That means a 3D surgery, 3-dimensional surgery. But it is not a surgery. It is actually a substitute of surgery. And he was the father behind this. He is Lars Lexell, who developed this frame on the basis of which the stereotactic radiosurgery. So if you have to just simplify, it's a surgery not in real, but with use of radiation instead of or to substitute for a surgery. So my next slide will make it very clear. There is a tumor which needs a surgery, right? Surgery needed, scalpel is seen, yes. But what if we use the radiation? How do we use? These are the gamma rays, and they are focused gamma rays of stereotactic radiosurgery. So this is a frame which is used, which was made by Lars Lexell, and that's why he's known as father of radiosurgery. 5 indications. I just want you to remember 1 or 2, which is most common. The first one, the most common is AVM or cavernomas. And the second most common is METS. Third is trigeminal neuralgia. Out of these 3 will definitely be there in the option. So if you see, AVM is there in the option, and then the answer becomes very easy. Last but one slide of the day. It's an image-based question. The entity is called trigeminal neuralgia. So the question which was asked is, which is the loop which causes compression of fifth nerve, that is trigeminal nerve? The answer is SCA. So this is a fifth nerve. This is the superior cerebellar artery loop which causes compression, and the patient has lancinating type of attacks on the face. And if there is something like this, how do you treat? So the surgery is known as microvascular decompression, and the question which was asked previously is known as Geneta's procedure. So that completes our today's class. Just before that, I would like to speak to the students about one reason which can cost you your entrance or your dream state. Dopamine. We all are addicted to dopamine in one or the other way. And you can see what addictions can cause us our dream rank and our dream branch. All these are levels which are the surging dopamine to such an extent. All of this, they are highly dopaminergic surgic. That means any of these activities can make you suddenly feel at high or very good. So one reason, just one reason which can stop you is your dopamine. But dopamine is not always bad. So there are other activities which can actually be helpful during this 1 year of entrance preparation, which I call it choose your dopamine wisely. Last slide, and then I'll say goodbye. You see this picture, all these have been wicket keepers. Wicket keepers, greatest of their times. One image is missing. Who? Because in the end, it all comes down to calm mind. The more calm you are, better your approach. And not only in your entrance, but also while treating patients or performing surgery. This is what is the ultimate difference. So this is how I want to conclude my presentation. And second class on our CNS based MCQs, or you can tell previous year questions, where we have tried to cover all questions from AIMS, PGI and recent NEET pattern as well. So apart from this, if we are missing out on any questions, please do mention in the comment section. I'm also sharing my ID where you can directly message me, mention in the comment section. And also, if you want to learn in a short form, that is 2 MCQs in 2 minutes, please do have a look at the videos. There are close to 50 videos which will definitely help you for your upcoming NEET PG. So once again, thanks to Dr. Kishan, the White Army, and my friend Dr. Akash.